Adult congenital heart disease. Surgical management and critical care of patients with congenital heart disease has continued advancing since the first successful reports of pediatric surgery in 1950s. In modern era, 90% of all newborns with congenital heart defects may be expected to survive into adulthood depending on the severity of their lesions. Meanwhile, it has been estimated that up to 10% of congenital heart defects may not be discovered until adulthood. As such, there was now more adults living in congenital heart disease than children, and the prevalence adult congenital heart disease uh, could double by 2050. It is estimated that 20% of the patients with ACHD have undergone at least one operation in adulthood. Still, the patient with ACHD continues to have higher mortality rates compared to general population. It is one of the most utmost important that the cardiothoracic surgeons are aware of the common lesions encountered in the patient with ACHD and well as the importance of the close follow-up and specific diagnostic management strategies in this unique patient population. One of the many challenges of managing the patients with ACHD is that they often present with sudden or progressive symptoms after being lost to follow-up for many years. As such, one differential diagnosis must be brought while considering a magnitude of etiologies and pathologies that may account for the patient's cardiopulmonary dysfunction with respect to individualized medical and surgical history. The initial evaluation of the patient with adult congenital heart disease began with a detailed history of and physical examination. Any patient with shortness of breath and palpitation should raise the suspicion of arrhythmia, deterioration, ventricular valvular dysfunction, etc. Other pertinent elements of history include the decreased exercise tolerance and fluid retention, all of which should prompt further diagnostic workup. Moreover, although the right bundle branch blocks may occur in up to 1% of the middle-aged population without other disease, and their presence in conjunction with the heart murmur warrants further evaluation. Because of continuous murmurs are less common in degenerative diseases, these always warrant further workup, especially in the presence of cyanosis or clubbing in patient without knowing the lung disease. However, in the patient with known congenital heart disease, it is not uncommon for the adult population to have a right-left shunts and or the pulmonary dysfunction that results in tolerable baseline uh, resting oxygen saturation less than 90%. As such, it is important to always ask patients if they know their baseline oxygen saturation and evaluate the current status of oxygenation relative to baseline. Echocardiogram is utilized for further diagnosis and workup of all the patients with adult congenital heart disease. This gives important baseline data with respect to the patient's ventricular and valvular function and provides information regarding the status of prior surgical repairs, prosthetic valve function, conduits, obstruction, etc. The routine echocardiograms and electrocardiograms are and rhythm monitoring is useful to evaluate the progressive arrhythmias, including the heart block and supraventricular tachycardias. Evaluation of an electrophysiologist is not usual and underscores the multidisciplinary care requisite for caring of these patients. Evaluation with cardiac MRI can be particularly useful in gathering the information with regards to pulmonary blood flow, atrioventricular or semilunar valve regurgitant fraction, and further characterization of the patient's functional and physiologic status. Right or left heart catheterization can be valuable, particularly when evaluating the pulmonary vascular resistance and elucidating prior procedures when the patient's history remains uncertain, that is, the prior stent placement and the septal defect closures. Other diagnostic tests may be helpful in these patients. For example, MR lymphangiography can be useful when evaluating the patient with Fontane's physiology and protein losing enteropathy and chylous ascites. The decision of when and how to surgically intervene on the patient with ACHD is not simple and must be individualized to each patient. The decision regarding when to operate includes comprehensive assessment of potential safety and efficacy of an operation. Surgeons must assess the safety and feasibility of external entry, which is often complicated by multiple prior cardiac procedures, myocardial protection, cardiopulmonary bypass, and more. Cross-sectional imaging is indicated for potential surgical candidates and is often accompanied by 3D angiography. Abnormal structure relationship can make it harder to re-enter into the chest support and patient throughout the cardiac surgery. Once inside the chest, anatomical anomalies, including the presence of veno-venous fistulas, codependent circulation, septal defects, a persistent left superior vena cava, anomalous coronary arteries, among the consideration may make a challenge to dissect out the heart safely and put the patient on cardiopulmonary bypass or arrest and adequately protect the heart throughout the operation. Those with extensive calcification, secondary prostatic implant, including the homograft or the conduit, place years prior to make the technical aspects, and in case particularly challenging, some patients may have had the previous percutaneous intervention, including the device closure of the septal defects, shunting, stenting. Many ACHD patients have the several cardiac catheterization throughout their lifetimes and will require the multiple central lines such as the peripheral duplex ultrasonography or indicated prior to the surgery to evaluate for the presence of arterial or venous peripheral emboli, which could complicate the peripheral cannulation strategies. The most common surgical issues encountered in patients with adult congenital heart disease are septal defects, single ventricular physiology, aortic coarctation, tetralogy of Fallot, Epstein anomalies, outflow tract obstruction, and transposition of great vessels. Ventricular septal defects are most common congenital heart defects and occur in 0.5% of children in US, and a number of specific VSD exist, including the conoventricular, perimembranous, inlet, outlet, and muscular VSD, most of which are diagnosed after the birth, and many small VSDs will close spontaneously early in life without intervention, and the patients are expected to have excellent long-term survival. However, even without the surgical intervention, the lifelong follow-up is warranted, and as these patients are at increased risk of aortic prolapse, infective endocarditis, and other related complications. Even with repair of the childhood, the residual VSDs may persist into adulthood, and some large VSDs may even go unrecognized throughout the early infancy and only presenting later in adolescence and early adulthood. Patients may present with the symptoms of dyspnea and exertional fatigue and even syncope and hemoptysis as persistent intracardiac shunting result in progressive elevated pulmonary vascular resistance and heart failure. And in these cases, a newly appreciated murmur on the physical exam is often the nidus for further cardiac workup, which is classically described as pansystolic murmur in patients with a VSD. Current guidelines recommended that the patient with the evidence of left ventricular volume overload and hemodynamically significant lesion QP and QS 1.5:1 warrant the VSD closure. However, it must be noted that the flow reversal with demonstrated right to left shunting Eisenmenger syndrome resulting with the pulmonary hypertension often indicates severe irreversible disease that portends a much worse prognosis. In such cases, the surgery is typically contralateral and even may worsen the pulmonary hypertension. VSD closure is typically only considered when the pulmonary artery systolic pressure are 50% less than the systemic pressures and the pulmonary vascular resistance is no more than one-third of the systemic vascular resistance. Although the VSD are most common congenital heart defects, along the newborn ASD may be more normal anomalies encountered in the ACHD population. Broadly, there are four types of ASD: ostium primum, secundum, and sinus venosus, and coronary sinus ASDs. Similar to VSD, the pulmonary and systemic flow QP and QS are more than 1.5% necessitate the ASD closure. Patient may persist with fatigue, shortness of breath, palpitation, arrhythmias are classically mid-systolic murmur in contrast to pansystolic murmur, typical VSDs. Workup begins with the echocardiogram and is followed by the right heart catheterization to evaluate for the pulmonary venous connection. pulmonary reactivity, and the pulmonary artery pressures. MRI can also be useful in adjunct for ASD evaluation. Treatment includes the closure of these secondum defects via the catheter intervention with a diameter up to 38 millimeter. On the other hand, the ostium primum, sinus venosus, and the large ostium secundum defects with poor rims as well as the defects are concomitant arrhythmias and usually require surgical closure. Some variants may require more extensive operative intervention. For example, the coronary sinus ASD are associated with persistent left superior vena cava and require a coronary sinus to the right atrial baffling. The sinus venosus defects are associated with the partial anomalous return of the pulmonary vein in 90% of the patient, and the surgical repair of these defects can be repaired by double patch closure of the anomalous veins and the atrium. The Warden repair transects the SVC to reimplant into the right atrium with the ASD closure. The ostium primum ASD, commonly referred to as the partial atriovenous atrial septal defects, are usually associated with the anterior mitral defect and which is often necessitate the repair and the annular stabilization of the ASD closure. In the single ventricle physiology, the Fontan procedure establishes a unique cardiopulmonary physiology that lacks a power source to facilitate the blood flow of the pulmonary circulation, which leads to chronic elevation of the right atrial pressure and the vena cava pressures with associated sequelae in long term. Specifically, Fontan physiology in the adult is particularly at risk of threatening arrhythmias and heart failure. Arrhythmias may also arise when the intracardiac baffle or the atriopulmonary connection becomes progressively obstructed over the time, which leads to severely enlarged right atria, causing the pulmonary vein obstruction and arrhythmias. Similarly, the pulmonary embolism secondary to sluggish shunt flow can lead to arrhythmias. Patient can also present with the atrioventricular valve regurgitation, which can lead to elevated pulmonary pressure, which once repaired can improve passive shunt flow. Occasionally, the patient presents cyanotic secondary to the residual atrioseptal defect or a persistent right to left shunt after Fontan. Other hallmarks of the failing Fontan, including the PLE, plastic bronchitis. PLE occurs in 10% of the patient and is one of the most ominous sequelae that its precise pathophysiology remains incompletely understood, and the patient present with the peripheral edema, pleural effusion, diarrhea, and hepatic congestion. Central to the management of the patient with Fontan's physiology is maintaining low pulmonary resistance and optimizing the function of the systemic ventricle. In patient with suspecting failing Fontan physiology, should be evaluated for obstruction, and if obstruction is noted, a catheter-based intervention, that is the balloon angioplasty stenting, is not possible, then the revision of the Fontan in conjunction with the antiarrhythmic procedure and the epicardial pacemaker insertion should be done concurrently. When the revision fails or when the surgery is unlikely to be successful, patient may be listed for the transplant and in some cases even undergo the heart-liver transplant evaluation through the experiences remains limited. Though coarctation is repaired in infancy, the patching is prone to development pseudoaneurysm, and most of these can be repaired endovascularly with ballooning and stenting. Endovascular repair has high propensity to aneurysm, and thus the area of coarctation should be followed by MRI. The open repair has been associated with aortobronchial fistula, which can present with the chest pain and hemoptysis. Patient with repaired coarctation should also have a lifelong surveillance for other comorbidities, and they are at increased risk of hypertension, intracranial aneurysm, and premature coronary artery disease. Many patients who have previously undergone the neonatal reconstruction for lesions of the RVOT have estimated 85% survival to the adulthood. Such reconstructions have led to the hospital admissions secondary to the right ventricular dysfunction, arrhythmias, and exercise tolerance. Pulmonary stenosis insufficiency is the most common pathologic consequence of imaging. Percutaneous pulmonary valve replacement is one of the potential options, but can be complicated by graft rupture and stent fracture. Where the percutaneous intervention is not possible, the annulus sparing repairs are favored. Transannular patching can progress to pulmonary insufficiency in the right ventricular volume overload, arrhythmias, and sudden death, 6%. The replacement over the repair is preferred, and if done at a younger age, this portends the normalization of the right ventricular function over time. Like many lesions, a moderate anomaly may present in young adulthood with exercise intolerance, arrhythmias, and fatigue. Sudden cardiac death is most likely to occur with an accessory conduction pathway. Echocardiography is the imaging modality of choice to evaluate the severity of the disease, and specific attention should be paid in evaluating the anterior leaflet shunting of the mitral valve function. Holter monitoring is used to evaluate for accessory pathways. Exercise testing is used to unmask the severity of the pulmonary hypertension and shunting. The surgical repair is indicated with deterioration of exercise tolerance, congestive heart failure, cyanosis, sustained arrhythmia, paradoxical stroke, and symptomatic tricuspid regurgitation, pregnancy, and oxygen saturation in 90% at rest. The repair methods are preferred and are discussed mostly. Supraventricular alveoli stenosis is associated with sinus of Valsalva and associated major artery stenosis. Repair is indicated when a discrete lesion has a mean gradient of more than 50 millimeters. Constellation of supraventricular alveoli stenosis, coronary peripheral and pulmonary arterial stenosis associated with Williams syndrome. Successful repair involves a patchy aortoplasty on the rare occasions and root replacement. Stenosis at the level of the aortic valve is often associated with bicuspid valve. The valve level stenosis associations include the coarctation of the aorta and the patent ductus arteriosus. The intervention becomes necessary when the symptoms of dyspnea, syncope, and angina becomes apparent. Similarly, the critical stenosis defined by a valvular area of less than 0.6 centimeters is an indication to intervene, or in those who regularly exercise and those who are going to become pregnant, and other indications include symptomatic, moderate, or severe regurgitation, and when the ejection fraction or the left ventricular end systolic diameter is greater than 55 millimeter. The root replacement is performed for diameter of 55 millimeter. Fibromuscular bridge is usually the culprit of the subvalvular stenosis. Over the time, the subvalvular jet aimed at the valve causes the aortic regurgitation. Surgical repair is considered when the mean gradient is greater than 55 millimeter of mercury and when symptoms develop or in combination with the moderate or severe regurgitation. The ventricular septal defect closure may raise the gradient and the obstruction may become apparent during intervention. Myomectomy is a treatment for the aortic valve, does not need replacement. Recurrence occurs in 20% of the patient requiring the lifetime surveillance. However, on occasion, LVOT is the tunnel-like or a conal procedure may be necessary. The recurrence in this group is high and early surveillance is necessary. Nevertheless, repair of the atrioventricular septal defect in the patient with LVOT obstruction should be done with a patch enlargement of infundibulum to prevent recurrence. All the patients who undergo patch repair should have a lifetime of surveillance to assess the endocarditis and aneurysm formation. One particular patient population with LV inflow and outflow tract obstruction are those with Sean syndrome. This cohort of the patient undergoes the multiple operations throughout their lives for the left side obstructive lesion. The surveillance is necessary because these patients are particularly prone to conduction delays and arrhythmias, and thus mandating the pacemaker insertion or a MACE procedure. The transposition. Historically, the surgical correction of the transport arteries involved the arterial switch, as for example the atrial baffling via the mustard or sending technique. Although these techniques have fallen out of favor, lasting complications of these procedures, specifically baffle obstructions, are still being managed in patients with adult congenital heart disease. Currently, the arterial switch G10 is preferred intervention in neonates with transposition through Rastelli operation is done for those with both VSD and pulmonary stenosis, although late complications are apparently rare and stenosis, occlusion, fistulas, and the long-term risk of the coronary artery disease in the patients after the arterial switch operation remain to be studied. Perhaps surprisingly, the anastomotic constriction appears rare after the arterial switch operation, and meanwhile progressive aortic insufficiency remain a concern as these patients grow older. Yet the moderate to severe aortic insufficiency has been demonstrated to occur less than 5% of young adults who receive an arterial switch in childhood. Reintervention on the adult patient after the correction of transposition of the great vessels, regardless of the congenital original repair, are often secondary arrhythmias, tricuspid valve regurgitation, baffle stenosis, as well as right to left shunt secondary to the baffle leak. The right ventricular outflow tract obstruction is determined by the gradient of more than 60 millimeters and the RV pressure and LV pressure of greater than 6 as noted in echocardiogram or the cardiac catheterization. The stenosis of the baffle can be treated with balloon angioplasty or patch augmentation. Balloon and superior vena cava and the inferior vena cava obstruction has a limited success in the adult population. SVC stenosis usually benign, while the IVC stenosis requires urgent intervention. Occasionally, stenting can be employed in those with angioplasty results in suboptimal. Atrial flutter is seen in 20% of the patient, while half of the patient have junctional rhythm or the sinus node dysfunction by adulthood. The treatment involves the transvenous pacing after the ruling out of baffle leak and echocardiogram to avoid paradoxical embolization. The pacing leads should be placed above the upper limb for the arterial switch or the left atrium. If the transvenous approach cannot be accomplished, the surgically placed epicardial leads are alternative. Post-operative care by the surgical team consists of the routine post-operative evaluation for weeks by the track of healing process. A specific patient population may be done by the recurrent effusion or drainage. In some cases, there is a need for MRI for further evaluation. Thank you very much.